In this video, we are going to continue our discussion of solving occlusal problems, and I want to take you through a few more basically options and sort of show you how the things that you're learning are not only going to be applied to simple procedures that you're going to be doing every day, but how this will allow you to do more complex things should you choose when you get out into the real world. Again, a big part of my practice is driven by these concepts, which allow me to do everything from aesthetic procedures all the way up to full mouth reconstruction on dental implants. So having a knowledge of this will allow you to do some pretty cool things in your practice. So again, we talked about that our decision of whether we're going to change somebody's occlusion is driven by the TMJ Occlusal Exam, and particularly in that middle yellow light type zone there. It's when we have signs of instability that are related to the teeth, the wear, the mobility, the migration, or sore musculature, but they have the healthy joints. And then we're also going to give you one example of that type 3 patient when the joint is basically not loadable, is not healthy, it's breaking down, and we treat the joint first and then move on to treat the occlusion once the joint is stabilized. That's really the most important concept. So again, with all these cases, we are going to be applying these basic principles of lines in the front, dots in the back, closing the mouth while the jaw's in centric relation, and making equal contacts all the way around, and then creating that anterior guidance in harmony with the envelope of function, which leads us to no ability to rub or have interference from the posterior teeth, really in any direction. So let's look at some examples. Let's look at Raj this morning. We saw him earlier as an example of somebody with headache pain. And again, when we seated Raj back into centric relation, as you'll see, he had a pretty large interference in the back, but he really didn't even have cuspid contact in maximum intercuspation. And so he couldn't go with any direction without rubbing on back teeth. Now, there were no signs of instability, or I should say very little sign of instability to the teeth, but all his issues was related with the musculature that was giving him headaches. Now, it's important to know not all headaches come from teeth, certainly, but some can. And so when we're doing our exam, if somebody has headaches, palpating the muscles become an important part of what we do. Beautiful dentition, but as I showed you earlier, when you look at his teeth, particularly in maximum cuspation, notice that his canines are slightly out of contact. That means when he goes into excursive movements, muscle activity goes up a lot, and if he is one of those patients that clenches and bruxes, they can stay sore. It's interesting that somebody else could be doing this exact same thing and the muscles wouldn't get sore, but they would start wearing their teeth out or working teeth loose. So remember, with occlusal disease, it is always the weak link in the system that causes the problem. We certainly didn't want to do anything to his teeth restoratively because they're so nice, but we're trying to figure out a way to create an ideal occlusion, and so we mounted the models in centric to see if we could equilibrate. Now, this is the first contact in centric relation, and you'll notice how far open his front teeth are. And when we tried to equilibrate him, it was just too much. So remember, reshaping is our first option, repositioning is our second option, and that's when we got an orthodontist involved. And one of the things we can do when we have really large skeletal open bites like this in centric is we can intrude the back teeth. And if we intrude the back teeth, then the jaw, because it closes on an arc, as the back teeth are out of the way, the front teeth have the capacity to close forward and upward the lower incisors to reach the cingulums. And so we checked his joints out. His joints were perfect, well corticated and nice and large. So this skeletal issue is not due to some joint change. His joints were great. And basically, with the exception of a few composites, his teeth were practically virgin. No crowns or bridges or missing teeth or anything like that. So Dr. Carl Roy, who is again a friend of Dr. Knight, trained by the same people. They do their supplemetrics in centric relation so that they can actually see the open bite like we see it on an articulator. And what this allows him to do with a software called Dolphin Imaging is to figure out how much he has to pitch up the posterior plane in order for the lower incisors to contact. And in other words, they can pick an arc of rotation around that condyle. Notice in the right picture there how you can see there's what looks like two molars on top of one another. The higher one is how far he needs to intrude it for the lower incisors to be able to pitch forward. So to be clear, his movement will just be intrusion of the whole maxillary occlusal plane to allow auto rotation. So our treatment plan is basically a prophy. We're going to need some help from zygomatic plates. I'll show you what they look like. The orthodontic treatment, the zygomatic plates are there to allow for intrusion. Then I'm going to do a phase 2 occlusal analysis to look at his bite again and then equilibrate him. So this is going to be both repositioning first and then reshaping by me. So these are what the little plates look like. They're just three little screws in the zygoma. And so that way when he does his orthodontics, he can grab onto it. They do need to put in a transpalatal bar. If they don't do that, the teeth will just kind of go labially. And again, we want to create a force that intrudes the teeth. And so there you can see the little spring attached to the zygomatic plate. This seems to be kind of scary, but honestly, the surgeons put those things in about 15 minutes. It's not a big deal. All right, it took about 4 months for the intrusion to occur, and after that, we held him there probably another 6 months just to make sure that there wasn't any relapse. And you can see how that the transpalatal bar that initially was off the palate is starting to land on the palate. Again, he made that thing off the palate the distance that he needed to intrude the posterior teeth. That's how he knew he would be done. So you can see the pre-ortho mounting and the post-ortho mounting. And he got me very close, although it's not perfect. And that's one of the things that I want you to see is to really idealize an occlusion. Orthodontists do not have the same specs that we do. They don't have the same tolerances. So almost always with an adult, we're going to be doing some equilibration afterwards. I can't equilibrate that one on the left, but I can sure equilibrate the one on the right. And so now that's what we're going to do. So we'll lay that patient back and do our 3 increments of loading to make sure we're in centric. Find that first point of contact that we saw on the articulator. My assistant will come in just with gauze to make sure the teeth are nice and dry. And then while I hold the patient in centric relation, she'll come in with our paper, and then I'll mark it. And what I'm going to do is find that first point of contact, and then following the rule that we discussed earlier by grinding on the side of the functional or stamp cusp, which is the upper lingual cusp or lower buccal cusp. We'll grind the side and start to adjust those inclines. And we will do that until all the teeth start to come together. We'll use a combination of finishing diamonds as well as carbide finishing burrs. And we're going to keep doing this. See, the premolars are starting to come in now. And we're obviously going to do this till we get stable stops on the front teeth. And then we can start to work out the excursive movement. So this is a very nice example of interdisciplinary treatment planning with the same occlusal goals. Utilizing orthodontics to do some of the movements that we need first, and then myself finishing the case using equilibration. Sometimes it might be orthodontics and restorative dentistry, but again, we're going to follow that Whittian rule and do it as conservatively as we possibly can. I'm starting to contact really nicely now, and now we can start checking excursions. And we want to just keep working and refining our marks until it's perfect. So equilibration is usually over a couple of visits. Took 3 visits to dial Raj in, and first one maybe was like 45 minutes, and the second, third appointments are about 20-25 minutes. That's typically what happens once you get pretty efficient with it. But this is about an 8-year-old case now, and Raj's headaches have basically been gone. And that's something we see pretty frequently um, if the diagnosis is correct in the beginning. All right, let's look at Kajiman, which is more of a restorative case. And with Kajiman, similarly, she's got some signs of instability, a little bit of headache stuff going on. But what she's really driven by is aesthetics. She's had a lot of different things done to her teeth, some bonding, some crowns, some CEREC. You can see how the lower incisal plane is worn and is angled. It's something we looked at earlier. And she just would like to have everything look nice. She said she wants everything visible in her mouth to look pretty, to look the same. Some of the black triangles that she's got, she'd like that taken care of. And so this is one of those cases it's going to be fun to figure out what we need aesthetically, but also look at what we need to do functionally to get her stabilized. She also mentioned if she could keep the gold on the second molars, she didn't really want to mess with that. She felt like that was strong and felt good, and she thought it was out of the aesthetic zone. So we do our exam. Again, aesthetic concerns are high. She does have history of clenching and bruxing. She's got some sore muscles to palpation on both sides. She has some exposed dentin. She's clenching. Not happy with her smile or the shade. But the good news is the joint exam was really, really pretty good. Just a little bit of tension on loading that I could resolve with a little deprogrammer. So as we go through this case, we're going to go and look at our 4 components in our treatment planning about equal intensity stops, anterior guidance and harmony with them with function, and the ability to disclude. And she fails really on all of them. From an aesthetic standpoint, we're also going to go through a series of pictures inside the wizard to get to a point where we can visualize where we want the teeth to be. And then we're going to transfer all this data to our articulator. And this is really what I want you to see is that as we do our 3-dimensional treatment planning, we want to get to a point where we have visualized where the teeth are going to go, both aesthetically and functionally. And what you're seeing here is a nice wax up that is in centric relation that's showing equal intensity contacts and definitely posterior disclusion, which is what we want. So we now have the capacity to treatment plan Tajiman, sit down with her, and she accepts a fairly significant treatment plan where we're going to be doing a combination of some crowns and some veneers on the lower, but basically rehabilitate her and transferring that wax up right into her mouth over a couple of days. And then once we get the wax or the provisionals in and we are happy with them, then we can start to finish her an arch at a time. Should also point out we had some soft tissue grafting done before the procedure to beef up some of the areas where she had insufficient attached tissue. And notice in this case we finished the lower first. I like finishing the lower first to establish that lower plane because it gives me a little bit more time to really refine the anterior guidance up top. And so once that is in, shade is ideal, then we can pack our tissues and take our impressions, have the uppers done. This is our bite record technique. And when she's all said and done, these are all Emax crowns, monolithic Emax in the posterior, and on the anterior they are Emax with micro layering. But this is fun stuff, and everything you've learned from the standpoint of occlusal design is definitely in this case. Some of the smile design stuff that you're going to get into, is also definitely here. We're also following good parameters for getting good margins and getting good healthy soft tissues, which is a part of all of this. So what I want you to think about this is these kind of cases just don't happen. We are applying really good principles of both biology, aesthetics, and function to cases where we can really make a nice difference in a patient's life. Let's dial it up a little bit more and look at Stefan's case, which is another one we looked at in occlusal disease, which is really kind of end-stage occlusal disease. An older gentleman who would like to try to keep his teeth, but when we sat down with him and really evaluated him, they were pretty much non-restorable. There just wasn't enough tooth structure for me to be able to do what I'm doing. Look at the size of those tori, look at the buccal exostoses. This guy had absolutely no pain whatsoever, and all the weak link in his system was just the dentition. He had just, over time, destroyed it, and so much tooth structure was worn that I think he may have even closed down a little bit, even though that a lot of times the wear will keep up with the extrusion, or the extrusion will keep up with the wear. So we sat down, in this case with my periodontist, and started looking at an implant option. And when you're doing a big implant case like that, that's the first thing we have to figure out is where the teeth are going to go. Where are they going to be from incisal edge to free gingival margin, and then figure out from there where the implant's going to go from the standpoint of not only direction but depth, because we need a very specific amount of space. And so one of the most important things with these all-on-4, all-on-5, all-on-6 treatments is so many of these cases are being done where the implants just go in, and then there's not enough space for the prosthetics. And so you can apply these exact same protocols to these type of cases. What's interesting about him is when you look, he had some early signs of wear all throughout his life that just kind of got out of control once he hit about 60, 65. And I think what happens is that once they get into dentin and they lose enough tooth structure, it just starts moving really, really rapidly after that. So what we did, he went ahead with this idea. So we took all our photographs and figured out from an aesthetic analysis where we wanted the teeth to be. But what I want you to think about is that if we're going to do a hybrid all-on-4, all-on-5, all-on-6 type treatment where it's a screw-retained prosthesis on implants, we're going to need 15 millimeters of space from the incisal edge to the head of those implants. And so when we do this, we're going to be taking this information of where we want the teeth to be and then going to the cone beam to be able to plan where those implants are going to go. And that is really the number, 15 millimeters of space. Now, one of the things that can help me is can I open this bite? And so what we did is just did a very rough wax up where I said if I can open his bite a little bit, then I don't need to cut quite so much bone away to get to the heads of those implants. And so this is by far from beautiful, but you can start to see how by adding to the teeth, top and bottom, how we can decrease his overbite and start leveling things out a little bit. And we basically made a matrix of this and just brought it into his mouth. Now, this is by no means a temporary, this is just an overlay so I can make sure it feels comfortable to him and that he can speak properly. Because speaking, especially the S sounds, is one of the things that can really tell us about whether our vertical is too far open. And he tolerated this pretty well. So with that information, we picked our shade, we took quick impressions of this or scans of this as our new starting point, and then we went to our cone beam to basically plan our implant placement. And what was great is that he did have a lot of room for us to be able to put 5 implants on the top and 5 implants on the bottom. Plenty of room both in depth and width, even with the amount of bone reduction that we were going to need to do. So this allows to, again, start to do our immediate denture that we're going to basically, at the day of the surgery, transition to an immediate load prosthesis. These are the surgical guides that are made. It shows us the trough where we need the implants to go. And from the incisal edge to that black mark is 15 millimeters. So the surgeon can put this in and know exactly where they need to level the bone to. That's the 15 millimeters we're talking about. Same thing on the bottom. So long day. The teeth are removed, the tori are removed, the implants go in. A provisional prosthesis was loaded onto the implants, and those stay in about 4 to 5 months, and then we finished them. So here he is, all said and done. And while there's slight variation to the occlusal design of this type of case, this is a case where we, instead of canine guidance, we go to group function, but we still have incentric, we still have equal intensity stops, we still have disclusion and protrusion on the balancing side, we're still in harmony envelope of function. It's just when we go into an excursive movement, we're going to keep it shallow, and we're going to use group function on the canine first bi and second bi. Notice the restoration of his face, doesn't look so overclosed. And that prosthesis basically just is flush with the ridge. You can see the little holes where the have been closed with a composite. You put Teflon tape in there with composite. And notice the tori, a lot of surgery to have the tori removed. Two more examples. This is a patient who is a TMJ patient who's had degeneration bilaterally off both discs and pain. And again, notice how far his chin is back. So in pre-treatment, he tended to want to hold his jaw forward. Sometimes patients will do that, will trigger some bruxing habits. And so the treatment was started with a full occlusal splint, maxillary occlusal splint. Again, equal intensity contacts on the splint, and then guidance, canine guidance on the splint. And you basically adjust this splint until the occlusion starts to stabilize. So phase one on this patient is going to be splint therapy. And these type of patients, it might take 6, 10, 12 months to get the occlusion completely stable and the patient comfortable. But it's important to do that because if you start changing the occlusion before the joint's stable, the occlusion is going to change again. So in this example, they're able to get him nice and stable. And now we're seeing the true discrepancy. And notice how far back the jaw sits. And you can look at this and imagine that the left joint is worse off than the right joint. You can see that because of how the lower jaw is shifting in that direction. So this case is going to be worked up. Couldn't equilibrate it, couldn't reposition it, we couldn't restore it. This is a case that was going to need orthodontic surgery. So orthodontics is done to level and align, and then mandibular advancement surgery is done in this case. And again, notice the difference in just the profile, the length of his chin. And with the wear and tear in this case, all that was done was just some bonding to put the edges back on the teeth. Notice how the canines are socked in there nicely. It's actually another case, courtesy of Dr. Doug Knight, one of his great teaching cases to show, illustrate what it is that we're talking about. The other thing that we're really learning is how much this helps a patient's airway. As you bring a jaw forward, that airway, these patients with joint problems where the jaw goes back, often the airway is very compromised. And notice how, in this case, how much the airway is improved. And that's great because it will definitely alleviate sleep apnea. One more case to show you that is sort of an interesting one. Somebody that had some occlusal problems as a young guy, but also they were exacerbated by the fact that he had an enamel issue that just caused the enamel to chip off his teeth. And so we knew early on that he was going to need a lot of restoration. You can see some of the things that are going on with his molars and his incisors here. But the other thing that we notice is a narrower arch form, and what we're doing a lot of now on these type of young teens and young kids is interceptive expansion. If the orthodontist hasn't gotten a hold of them and expanded, we can certainly do this with Invisalign. That was really our first thing that we did once he hit about 13, 14, is we just widened his arch and created really nice arch forms. Got rid of the crowding on the lower and got him ready. We did some bonding to kind of plug some of the holes there until he was ready for the sort of the aesthetic reconstruction, which is what his parents wanted done for him. So we've got everything done in Invisalign and set up. Again, you can see the width. Imagine more room for the tongue on a case like this, which is important. Narrow arches, as people get older, are prone to some of the issues that we might see with sleep apnea. And so now we're going to do the aesthetics. And so post-ortho, when he's ready, we will go ahead and mount those models on an articulator and centric relation. Because he has a bit of a deep overbite, we're going to try to do this work without hardly preparing his teeth. So doing a veneer, sort of a combination in between a veneer and a crown, where we are doing it very, very minimally invasive, minimal invasive type prep. So there's pre-Invisalign, post-Invisalign. Again, seeing some of the issues with the tooth structure itself. And so we're going to go through our wizard analysis. We're going to figure out where the teeth go and get to the point where we're going to lengthen things a little bit and then open his bite a little bit on the articulator. So again, figuring out our lower occlusal plane. Remember, your lower incisal plane can be straight or convex, but not concave. So this is appropriate. It's a nice curve of SPE. We do some additive waxing to the facials and the incisal edges, as well as the lingual contour of the uppers, and establish our new occlusal vertical dimension, and being sure that we have in-centric relation, good posterior disclusion. So once we get the wax ups done, patient's brought in after mom and dad and son accepted the treatment plan, and we get him in provisional restorations, making sure they all fit, he's speaking properly, they like the length and the contour, and now we can start finishing them. So here's the restorations. What I want you to appreciate here when you look at them is that the design is maybe something different. Onlay veneers on the back, and notice that the lingual contour, the veneer, the posterior teeth go from the facial over the occlusal surface, and the anterior restorations are a taco design on the upper and a standard veneer on the lower. I'll show you what I mean by a taco design here in a second. Yeah, there you go. So if you notice the look of these, we do not break interproximal contact. So what this allows us to do, and you can see the prep model, look closely at the design of the restorations, and look at how conservative these preps are. There's a very small margin there, and we do take some two structure in the line angles, but everything else is very, very conservative. Somebody that's young, I want to leave as much two structure behind as I possibly can. So this is all going to be air abraded. The teeth will be air abraded. We'll do a total etch technique with phosphoric acid and then bond. So I'm showing you some contemporary dentistry, but what I want you to appreciate is that the principles of occlusion are the same. Notice that his bite is a little more open. This is open maybe about 2 millimeters, increased his vertical dimension about 2 millimeters to gain that necessary space. And there he is, all said and done. We waited till he was about 21 before we did it. So he was wearing a bite splint on the top and a retainer on the lower after the Invisalign work was complete. Again, this is a lithium disilicate material, a new material called amber, similar to Emax, and we did the monolithic with micro layering. So just a little bit of micro layering on the facial of all these restorations. So there's a nice example of taking a young man and sort of growing up with him and setting him up for success for some nice work as he gets a little bit older. So this has been our last segment with you. I want you to be excited about occlusion. I know it seems a little bit esoteric, but there isn't anything that you're going to use more day in and day out as you do basic fillings and crowns and bridges. And if you should start to train after dental school with some place like the Dawson Academy to learn to do more advanced things, it just becomes a part of the culture of what you do. So it's been a pleasure to be involved with your class. Good luck in your studies. Have a little fun, work hard, and be glad that you decided to be a dentist because it's awesome. Take care. See ya. Bye-bye.